GI pathology, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, viral hepatitis, hepatic encephalopathy. All right, so pretty much this is all of our liver pathology. So let's start off with alcoholic liver disease. So when a patient drinks alcohol, our liver pathology is going to progress in stages. So the first stage is going to be hepatic steatosis, which is macrovesicular fatty changes. And the reason I'm making a key point there is because that is different than microvesicular or microsteatotic changes seen in Ray's syndrome. So Ray's syndrome has microvesicular steatosis, whereas hepatic steatosis in alcoholic liver disease causes macrovesicular fatty changes, okay? And the reason behind that is because you have triglyceride accumulation due to an overall decrease in fatty acid oxidation. Now, that is hepatic steatosis, and it is reversible. So this is the first step, okay? So if alcoholics, they drink a little bit, and if they stop their alcohol use, then this can be reversible. Next, if they don't stop, they can go into alcoholic hepatitis. Alcoholic hepatitis, what the key thing is here, is that you're going to have intrahepatic neutrophil infiltrates, all right? And you're going to see swollen and necrotic hepatocytes, all right, with Mallory bodies. And Mallory bodies, take a look what that looks like. They have like damaged keratin filaments. They're intracytoplasmic eosinophilic inclusions, okay? But the takeaway here is this is long-term consumption of alcohol, okay? And it's going to cause swollen and necrotic hepatocytes with the key thing, neutrophilic infiltration, okay? Intrahepatic neutrophilic infiltration. And I want you to remember that, okay? Next is going to be alcoholic cirrhosis. And this is essentially just cirrhosis. It's irreversible, right? So what do we know about cirrhosis? It's kind of defined as regenerative nodules surrounded by fibrous bands. So you have fibrosis and regenerative nodules of hepatocytes. Take a look at what it looks like. Those photos are very important for alcoholic cirrhosis, okay? So I want to go through every single one of these real quick so you know kind of the key points to look out for. Hepatic steatosis is macrovesicular fatty changes due to triglyceride accumulation and an overall decrease in fatty acid oxidation. Alcoholic hepatitis is intrahepatic neutrophilic infiltrates with Mallory bodies. And alcoholic cirrhosis is fibrosis and regenerative nodules of hepatocytes. Ray's syndrome is going to be microvesicular steatosis or fatty changes associated with aspirin usage in young patients. All right, so those are those high-yield, hard-hitting facts that you should know. Now, take a look at all the photos and what they look like because they do question you on what they look like as like the histology of the liver. Next is non-alcoholic fatty liver disease. So this is associated with metabolic syndromes like obesity. So this is very high yield for patients specifically in America. We struggle with obesity as a population. So you don't have to have alcoholism in order to have liver disease, okay? Just as fat deposits on the outside of the body, it can also deposit on the inside of the body, specifically in the liver, and it can cause fatty liver disease, non-alcoholic fatty liver disease, okay? And obesity is the leading cause of that. Now, non-alcoholic fatty liver disease, once again, it's reversible when you lose weight, but it can progress to cirrhosis. So keep that in the back of your mind. Obesity isn't just something that's just like benign. It can progress to cirrhosis or hepatocellular carcinoma, okay? And they want you to know that it can potentially progress into cirrhosis. Next is autoimmune hepatitis. What you want to know about autoimmune hepatitis is that if you see a positivity for anti-smooth muscle antibodies, then boom, that's your answer, autoimmune hepatitis, okay? They will also say portal or in periportal lymphoplasmacytic infiltrate. That is also a sign for autoimmune hepatitis, but positivity for anti-smooth muscle is very, very high yield and very highly associated with autoimmune hepatitis, okay? Don't forget histologically they could show portal and periportal lymphoplasmacytic infiltrate. Okay, that's your autoimmune hepatitis. Now let's talk about viral hepatitis because they love to question us on viral hepatitis when it comes down to it. So first is Hep A. So hepatitis A, and you're going to learn about this in your sketchy video, so I'm not going to really go too in depth in it. I'm just going to talk about what you see on liver biopsy. For Hep A liver biopsy, you're going to see hepatocyte swelling with Councilman bodies. Okay, monocyte infiltration, Councilman bodies, and hepatocyte swelling. Hep B virus, you're going to see ground glass appearance. They can say that it's like finely granular, pale pink appearance. That's ground glass appearance with cytotoxic T cell mediated damage. Okay, so it's like a granular ground glass appearance. Hep C virus has lymphoid aggregates with focal areas of macrovesicular steatosis. Okay, so those are the key viral hepatitis that I want you to know and what you see on liver biopsy. okay? And that's going to help you on question stems and examinations. Lastly, I'm going to talk about hepatic encephalopathy. Hepatic encephalopathy, once again, I discussed it multiple times, but I want you to fully understand this. You have an overall decrease in ammonia metabolism, so that leads to an overall increase in ammonia. That ammonia is going to lead to accumulation of glutamine in astrocytes, okay? And that leads to an overall decrease in glutamine to glutamate conversion. So we have an overall decrease in excitatory processing, okay? So you're probably like, what? Like, what are you talking about? Okay, let's slow down. First, we have an increase in ammonia, all right? And that increase in ammonia is going to cross over into the CNS, which can be converted into glutamine. And so we have an accumulation of glutamine. And what happens is that glutamine is going to enter astrocytes. But normally, glutamine is used to be converted into glutamate, which is our primary excitatory neurotransmitter, as we discussed in neuro. But since you no longer have any glutamine available because it's all entering astrocytes, you have an overall decrease in the conversion of glutamine to glutamate. And so you don't have enough glutamate. So without enough glutamate, you have an overall decrease in excitatory processing. So that's what causes the encephalopathy. All right? Once again, not too high yield, but I just want you to have a full understanding of what's going on from the hepatic encephalopathy process. So remember, in order to kind of treat this, you could give them lactulose or rifaximin. Okay? And we discussed kind of the mechanisms of action of each. All right, that's all for our alcoholic liver diseases, autoimmune hepatitis, viral hepatitis, and hepatic encephalopathy.